y'all had a good night. I hope that y'all got to rest a little bit and that we're going to move along without too many problems today. So today we're going to pick up on where we left off yesterday, and I'm going to focus on, we're still talking a little bit about polymorphisms, but what we're going to do is we'll talk a little bit about some areas that are sort of emerging or that have emerged, because like I said, with the polymorphisms, and again, you'll be getting a lot more of this when you take the additional courses, your advanced course. I think there is one whole class that deals with primarily polymorphisms, where you'll go into specifics with the psychotropic drugs that you'll be prescribing. And so what we've had is, again, there has been a lot of work and recognition focusing on drug metabolism, okay? And as I said yesterday, we do know there may be polymorphisms that may affect the receptors and enzymes and things like that. And that we haven't had as much work as we've had on the liver enzymes, but we are seeing more work emerging. And probably one of the biggest areas, or areas that second to the liver enzymes that we've seen work on polymorphism, is dealing with drug transporters. And so with drug transporters, basically what you're looking at is these are molecules that typically are involved in transporting a drug across the membrane. So as a result of that, we see that a number of drug actions, for a drug to work, they have to get into the system. And we do see that these molecules, and one of them we'll talk a little bit about this morning is P-glycoprotein, is that these molecules are involved in moving drugs. For example, we'll see them involved in moving drugs from the GI tract. So basically moving them into the cells so that they can be eventually moved into the bloodstream. Also, they involved in distribution because of they are moving it. Once the drug gets into the bloodstream, the drug will be transported into the tissues. And then it'll also be involved in excretion, which will mean where we're transporting the metabolite or the drug out of the tissues into the other things. Now, interestingly, we have studied a lot of transporters. There's a lot of work on transporters in general, and probably the one that you guys have probably been exposed to the most are the ATP membrane transporters. So, for example, when we talked about moving ions back and forth across the membrane, ATPase, ATP and ATPase has been extensively studied. And we're still studying in those biochemical mechanisms. However, one of the things that we are seeing is, or that we are seeing more emphasis on are these particular systems, what are the polymorphisms associated with these particular systems? So that's one of the things that you're going to see more of, okay? And we're going to get more definition with regard to these. But right now, again, I think most of the emphasis has been to focus on the situation where that, like I said, the enzymes. So looking at that, let's take a look at a couple of them. And in particular, probably again, there's been a lot of work on ATPase and the ATP membrane transporters. We're going to talk about, for the next few minutes, P-glycoprotein. So P-glycoprotein, it is actually a member of the ATPase family. So when we say it's a member of the ATPase family, it means that it has part of this function is going to involve ATP. And we do know that this transport mechanism, this particular transporter, is going to be responsible for taking things out of the cells. Okay, so the efflux of particular substrates, and things that we see is bilirubin. So that is going to help move bilirubin across. From a standpoint of drugs, we know that some of the chemotherapeutic drugs, the anti-cancer drugs, get transported out of the cells. Cardiac glycosides. The cardiac glycosides is one of the first ones that we recognized could be a real issue because we found that sometimes the P-glycoprotein could affect moving cardiac glycosides out. Protease inhibitors, glucocorticoids, those are just a few examples of drugs that we know are involved or that use the P-glycoprotein transport. Okay, So what we do know is that this transporter is expressed in several tissues. Because it's expressed, typically we think that when we see expression of these, this ubiquitous spread across there, is basically this suggests to us that that it has a role in a number of things. Now, one term you may not have heard is xenobiotics. Xenobiotics is a term that sometimes refers to both drugs as well as other substances, chemicals, and so things. So it's other things other than drugs. But we think that this transporter, the P-glycoprotein, is very important for moving metabolites, for example, into the urine so they can be excreted, moving bile, and moving things into the intestinal lumen. So again, because of the widespread distribution of the P-glycoprotein, this strongly suggests that this is an important molecule and that it is going to, that it has a role. And we have identified roles, like I said, with certain compounds as you've seen above. And this list is not all inclusive. We know up in the blood-brain barrier that the P-glycoprotein is actually present in the choroid plexus, and it is going to limit the entry of many of the compounds into the brain. So it's part of that blood-brain barrier that we talked about yesterday. Yesterday we talked about structural components, which was the tight capillaries and the small pores and the myelin that surrounds the capillaries. But in addition to that, the P-glycoprotein is going to limit. So some molecules have to be transported across, and the P-glycoprotein is going to be required, or if the molecule doesn't go through the P-glycoprotein, it can't get in. And the P-glycoprotein is going to be saturable, so it's only going to let a certain amount in. So we do see that that's an important thing for restricting access to the brain from certain compounds. And it would make sense that if someone had a problem or had a polymorphism of this P-glycoprotein, that it could have an impact on either letting too much in or not letting enough in. So that would be an issue. As I said a few minutes ago, probably the first time we recognized the significance of the P-glycoprotein polymorphism was one in the intestine. And digoxin, how many of you, other than me mentioning it yesterday, how many of you have heard of digoxin? Okay, several of you have. Okay, one of the digoxin used to be used quite a bit for heart failure. It's present in foxglove. My wife and I think love foxglove the way it looks. We can't have any in our backyard because we have dogs, and foxglove can be toxic to plants. It was actually when it was used back in the 17 and 1800s and before, pretty much it was used. It was harvested from foxglove. But the cardiac, the digoxin. One of the things is it is one of those drugs. Also, if you remember yesterday when I listed the list of drugs that had low that were, I gave you some examples of had low therapeutic index. Digoxin was one of them, and which means that it doesn't take a lot of digoxin. The dose for the therapeutic effect is very close to the toxic effect. And when we were using digoxin, one of the biggest things, more frequently than what we're using now, one of the biggest concerns we had was basically the toxicity with digoxin because of the very low therapeutic index. So what we discovered is that some patients, the digoxin demonstrated a higher bioavailability. And what we're talking about with bioavailability is how much drug gets into the bloodstream, okay? And so when we look at all the drugs that are taken orally or even by injection, typically they can range from almost 99% all the way down to some drugs. In fact, some drugs you may prescribe, you may find the bioavailability is only about 40%, which means that, for a given dose, only about 40% makes it into the bloodstream. But what happens is, so we have to give a higher dose to get that 40% in. So what we recognized is that there were some patients that at a given dose of digoxin were showing toxicity. And we can measure digoxin levels in the blood. And what we were seeing that in some patients that given a dose of digoxin, one of the things that happened was that their P-glycoprotein was a little bit different, and it basically allowed more digoxin to be absorbed. So what we saw was that there were some patients that had a higher bioavailability. So for a given dose, more got into the bloodstream and therefore showed toxicity. That indicated that, that told us that we discovered the reason it occurred was that there was due to a polymorphism of P-glycoprotein. Okay. That could be, be disastrous for those particular individuals. So we do start off with much, much lower dosages now. But I'm not aware that when somebody's fixing to get digoxin do we do some sort of assessment of what their P-glycoprotein is. Okay. There are other drugs that are probably affected. To what extent, we're still learning. But so that always shows up with the question with regard to how important is this polymorphism? What's its clinical significance? Because if we have a drug that has a high therapeutic index, so there's a big separation between the therapeutic and toxic effect, that polymorphism may really not even show up, okay? But we have seen at least one example of where that a polymorphism of the P-glycoprotein actually is associated with a significant clinical issue. This probably, I would just simply say, this probably would be more significant if we were using digoxin much more than what we are. But since we cut way back on using digoxin, again, most people have just started off with lower dosages. Now, here's this figure here is basically showing you some things with the P-glycoprotein. So what we have here is that the P-glycoprotein transport you actually see here in the sort of in the brush border, this green brush border look here, okay? And so when we have one of the things that is suggested that could occur is that we might have a situation where that a cell becomes resistant. And one of the ways it may become resistant is that because of a polymorphism, or cell may show resistance, is because of polymorphism of P-glycoprotein actually basically pumps the drug out. So here what you see on the left-hand side of this figure is the drug is being delivered right here, basically through the bloodstream. And so the drug leaves the bloodstream, goes into and goes to the cell. And so basically it's getting taken up into the cell. But then what happens is you've got a polymorphism here where the P-glycoprotein transport is very active. And so what happens is that although the medicine comes in, basically the high activity of the P-glycoprotein transport is actually pumping the drug out of the cell. So the cell may show resistance mainly because we don't get enough drug to stay in the cell to produce an effect, okay? So that would be one thing that could happen. Then the other thing that can happen is we may have a situation where that we've got if we change the sensitivity, we can get that. So by blocking the P-glycoprotein pump in this cell, then what happens is now it becomes effective. So here you have on the right-hand side, the drug is being delivered. When it gets into the cell, then one of the things that we're thinking about is that we could use some sort of inhibitor molecule that would slow down this P-glycoprotein and block that pump, either block it or slow it down. And that would allow the medicine to, or the drug to accumulate it in the cell. And as a result of that, then the cell would, we would have a therapeutic benefit. But in this situation, the polymorphism is pumping out the drug faster than we can get a therapeutic effect. So what our option will be is either to use another drug that isn't affected by the P-glycoprotein transport, or basically potentially use some inhibitors of glycoprotein. So those are some things that we've come into play. And so it might be that if somebody is known to have a polymorphism of this transporter, is that we would choose drugs that aren't acted on by the P transporter, don't go through the P transport, or we would potentially use some sort of inhibitor. One of the problems with using inhibitors is you're adding another drug there. And so, as far as I'm trying to think of, what type of drugs that we have that maybe inhibit them, and those are somewhat limited there. So just to sort of sum up, to give you sort of what we know with these polymorphisms, so this little primer that I've given you here to set you up so you're at least aware of them, and when you go into this in more detail. We do know that there's several that have been identified, and there are additional ones that are coming out that are being identified. But the ones in particular that may affect you, well, let me just go through some of these. And the ones that you probably need to be the most aware of is the ones I have in red there. So we do know there's a polymorphism of the gene for angiotensin converting enzyme. What it does is basically any of the ACE inhibitors, it could affect that. We do see arachidonic 5 lipoxygenase, the leukotriene inhibitors may be affected by that. The beta receptors, beta 2 receptor in particular, that would affect the beta 2 agonist. The bradykinin B2 receptors, that is acted on by the ACE inhibitors. But the ones that would primarily affect you, really when it comes down to, is these, the ones that there are polymorphisms of dopamine receptors, and the antipsychotics are going to be potentially a concern. What you would be worried about that with these polymorphisms is that would you get a therapeutic response due to the specifically the D2 receptor? But the other thing would be is if we have a polymorphism where that D2 receptor is altered in another way, we may be more subject to side effects. And then down on the last part here, the serotonin transporter, you may have some polymorphisms of those, and therefore antidepressants, in particular the SSRIs, may not work as well. And again, you'll get into this more and things to look for and identify when you get into the advanced course. Let's see. There we go. Now, in addition to the direct effects, some of these polymorphisms may become important with indirect effects. Okay, that's not that we have a polymorphism of what we're looking at specifically. So one of the things that we've noticed is, for example, that women in particular, that are, because they're taking oral contraceptives, there are some women who inherit some coagulation factors, which under most circumstances doesn't affect them. But when you throw a drug in there, like an oral contraceptive, then what we may be dealing with here is that it may make them more susceptible to thrombosis. So there are a couple of proteins which, if the women inherit that, then basically they are more susceptible to coagulation or to certain drugs that may produce coagulation. Another thing which actually may predispose people is, and this may come into play with you, is, for example, there are variations in the sodium or potassium transporters, and that can set up for the long QT interval. So the drugs that you would be concerned about if that occurred, although the prolonged QT syndrome, basically those people may do fine, and their QT interval is slightly longer than normal, or is longer than normal. And that is fine for the most part. But when you put a drug in there that may affect the QT interval, this may make them more susceptible to the toxicity. And in particular, the antipsychotic drugs would be something. That's one of the reasons why we suggest measuring the QT interval prior to giving antipsychotic drugs, because we may have people that already have prolonged QT intervals, which may be a genetic effect. We also see that there's a APOE, which is dealing with phospholipids, and we might find that there's a certain type of people that they're not going to respond as well to lipid-lowering drugs. So again, these polymorphisms, without the drugs, without certain drugs put on board, they don't affect the drug particularly, but they may predispose the patient to some of these side effects of the drugs. So what happens if we don't reckon, and we do now, I think most people know about polymorphisms. Sometimes they're overlooked. We do see that there are still some clinicians, I've got physicians here, we do see some clinicians that just don't think about it, in the sense that it's like, okay, yeah, we may have a fast or slow metabolizer, but they just simply will give the drug and not wait and see. So what we're seeing is, as we've moved forward, there's more acknowledgement that if we know there's a genetic polymorphism that's there, then we should take that into consideration with dosing, okay? We don't have any very, very large prospective studies, so it's very difficult. Now, one of the things that's helping, and a little bit later on this afternoon, the area we're going to talk about is we're going to talk about the FDA and so forth. But one of the things that's helping is the FDA now requires drug companies to put indications on if there are known polymorphisms and things like that. That's supposed to be included in the label. So there's been an increased duty that's been imposed upon drug manufacturers to examine polymorphisms and to determine if that, and also to if those show up in clinical trials. So that's there. So that's what I've got by the red area down, is the information concerning these polymorphisms is now being included in the package inserts, okay? So that is a requirement for the FDA, by the FDA, of the drug companies, as well as to update this on a regular basis there. Now, the only problem with this is there are, and I've been doing legal consulting for 30-something years. I am still, to this day, surprised at the number of clinicians and that when they're asked, have you read the package insert? And their answer is either no, or I read it several years ago, okay? So there are people, and I have seen people, literally clinicians prescribing, that have never looked at the package insert. So one of the things that I'm going to tell you is, for all of the drugs that you prescribe, there's two things I'm going to tell you. Number one is, make sure you read the package insert and you revisit it every now and then, you know, at least preferably every year. But I'm going to give you something that will help you, where that you don't have to sit down and read the package insert in its entirety as frequently. But we're going to talk about a MedWatch, what is called the MedWatch program, this afternoon. And I'm going to tell you how to subscribe to that, and that will give you updated information. So if there's new information that comes out, that may mean, let's say you read the package insert every year. One of the things that happens is that if something comes out, you know, 3 months from now, you would hear about it. Okay. So maybe in your annual review of the drugs that you're prescribing, but you would normally see it. But let's say it comes up, you know, 3 months after you read the last package insert. And I'm going to also show you on the package insert, the new package inserts talk about when the last changes were done. So this will be something. But I encourage everyone that on the drugs that you're prescribing, go online and print out the package insert and have it there so that you can look at it. Set you up a file if you want to read off your computers, that you can just save the package insert. And that way you have it there and can look at it very quickly. Because the package insert is according to the Code of Federal Regulations, the package insert is supposed to provide all the information for the safe and effective use of the drug. And I would say that it does contain majority of the information, but as new stuff comes out, and some things you're not going to be able to include on the package insert, but you should be familiar with it. That should be at least your bare bare level of knowledge for the drugs you are prescribing. Okay. All right. Here's the, I like this slide here because I like it, but it doesn't mean I can ask a question on it because it's very difficult to ask a question on here. So basically, when we look at pharmacogenetics, this sort of sums up what we're talking about here. So if we take a group of patients, and that's what's in the middle here. So this is our group of patients right here, okay? So there's going to be a few patients where the drug is toxic, but basically it's not beneficial. So the people will have side effects, but sometimes the side effects are worse than the benefits, or sometimes there's hardly any benefit there. You will have the majority of your patients are, well, I tell you what, see if I can do it this way. The majority of your patients are going to fit into this sort of silver white group down here, where the drug is not toxic and it's beneficial. Now, when I say his drug is not toxic, doesn't mean that the drug doesn't have side effects, but it means that the person can use it. We can use it in these patients. And all these people are getting the same diagnosis and getting the same prescription. And then we have some that's the yellow group down here on the lower left. Those people, pretty much the drug doesn't have any effect in them, okay? So for example, if it's the P-glycoprotein, we might have where the P-glycoprotein is literally pumping out the drug, so they're really not getting any benefit, not getting anything there. And then we have a small group up in the upper left-hand corner, which are the drug's toxic, that's beneficial. So this all reflects things that can occur with these pharmacogenetic or these polymorphisms that occur. Majority of people are going to be able to use the drug. There's going to be a small number that the drug just doesn't work in. There's going to be a small group where the drug is toxic but beneficial, and that's the ones that are going to be the hardest to make your benefit risk assessment. You have to really determine what the toxicities are. And, for example, if I'm dealing with a cancer patient with a stage 4 cancer diagnosis, I'm gonna take a chance on some of these this toxicity. If let's take an example of clozapine. There are people that basically they haven't responded to anything else, and we're down to like the 4th choice, and clozapine is there, and so we can use it. The drug will be beneficial, but I have to be worried about the toxicity. So what I'm going to be doing is I'm going to monitor those patients really closely. If I'm going to use the drug, I'm going to have to be looking for the specific, things that are there. But really, when it comes down to is the group in the lower left-hand corner, the drug's not toxic, not beneficial. Sometimes what will happen is a clinician will keep trying to push the dose, and they can eventually get to a point where it may be very toxic, but still not be that much beneficial. And also there's the group that is where the drug is toxic but not beneficial, and we just want to try to, if we see that immediately, we're not going to dose those patients there. But the hardest ones are going to be where the drug is toxic but beneficial. That is going to be the hardest or more difficult assessment you're going to make as far as benefit risk. Now let's look at a few other things. This morning, we're going to talk about a few other things that may affect dosing and pharmacology, okay? So one of the things is we may see gender differences, all right? So one of the issues that comes into play is there's a term called volume of distribution, and that is what I have where I say VD, that stands for volume of distribution. This is actually a calculated value, and what it basically is referring to how the drug distributes in the body. So what we find is that most of the drugs that you're going to prescribe are going to be lipophilic. Most drugs that are lipophilic are going to get into the brain, okay? So what we find is lipophilic drugs tend to have greater volumes of distribution. Anytime that you see where the volume of distribution exceeds the blood value, the volume of blood, That means it's distributing outside the vascular compartment into the tissues, and lipophilic drugs do that. Hydrophilic drugs tend to stay within the blood because they're water soluble, and that's where the water solubility is. So what we find is that typically women are going to have larger volumes of distribution because of lipophilic compounds. Because women typically have, compared to a same size male, females have more body fat. And so we typically see that there is a greater distribution of the drug in women because of lipophilic drugs. The hydrophilic drugs, the water soluble drugs, are going to be, the volume distribution tends to be lower. And I've got a paper on pharmacokinetics, which I'm going to give you, which is will help explain some of this, although we're going to talk about this today. And the paper, we'll give it to you to look over for when you go to lunch. So I'll give you a little extra time for lunch. We're also going to do the questions, and we're going to, Marissa will keep the exam. So today is you're going to have, right before lunch, we'll have have 4 questions dealing with this morning's information, maybe a little overlap between yesterday. This afternoon, close to the end of the session, we will do probably in the mid-morning break or mid-afternoon break, we'll probably do the other questions, the other 4 questions. And then at conclusion, you will have 10 questions, which again, you're not being graded on. It's just basically the post-test. So that, we'll probably give you the post-test no later than 6:30 is what I'm thinking. I say 6:30, no later than 3:30. And then you'll have about 20 to 30 minutes to finish that. That's going to be 10 questions. And then you'll have your exam for this material, which will be, it'll get posted like normally. And as my understanding is, it'll be posted, and should be posted around Wednesday, and it will be up until the next time we meet, which I think is that 3 weeks from now or 2 weeks from now? I can't remember what the date is off the top of my head. So anyway, we'll do that. So let's look at some other gender differences now that I've digressed a little bit. Some other gender differences that we have is that typically, or I should say gender and age differences is what we're going to talk about. These are not in red, so again, this is more just for information. We see that typically in the adult, the P450 overall activity, the cytochrome P450, is usually higher in adults. Number one, we've got adults have larger livers than the fetus or the neonate, and also we have the enzymes have developed. So that's there. We do see that the cytochrome P3A tends to be a little lower in newborns. This may explain why they may be more susceptible to drug toxicity. But we also see that, for example, looking at younger individuals, that, we have 3A as the general thing, and then we have the various subtypes. We have, 4, 5, 6, 7, those things. So we see something like the 3A7 accounts for about 85% of the total P450 that we see in fetal liver. That's the predominant one. But what happens is the 3A7 levels over their first year of life basically decreases to about what you see in adult levels, and then 3A4 becomes the major enzyme. So again, within the first year, we're starting to develop where that we have primarily the 3A4, which is, probably handles most of a large portion of the metabolism of most compounds. So the other thing is that when we're older, we don't really see a change in the 3A4 levels, but there are some changes that are more physiological that occur. So one of the things we see about late old age. What exactly is that time frame? I would say probably in the mid to late 70s and older. What we see is liver mass goes down by about a third. And so when you, the enzyme activity is the same, but what you're seeing here is that the liver mass goes down. So if there's less liver mass, there's going to be less enzyme, but the activity of the enzyme is the same. Probably the biggest thing is that as you get older, you start getting a decreased blood flow to a lot of organs, not only the liver, but the GI tract and so forth. But we see about a reduction of about a third, a little more than a third of liver blood flow, which means it's going to take longer for the drug to circulate and be cleared by the liver. And the overall volume of the liver goes down anywhere from about a fourth to just under a half. So some of the changes that we see in aged people, not counting for disease-mediated changes, but basically what we see is that the liver blood flow and the liver mass decreases. So by doing that, that basically causes a reduction in it, and that could mean that the drug stays around and in the body longer and therefore could possibly accumulate. So that's going to be an issue that we just deal with. So I keep losing my screen there. So we do see, again, as I said yesterday, we do find that there is a change. We typically see that at either ends of the age spectrum is we tend to see more of an issue with side effects and adverse events for various reasons, but that is one. So in the very, very young, we're having a development of the liver, change of the enzymes. And in the very old, we're having the enzyme activity doesn't change, but primarily it's probably the reduction in liver blood flow and the reduction in liver mass that accounts for it. Brady, you just asked a question, and Kirsten, you echoed it. Marissa, if you can, I think she can post the answers to the quizzes this weekend. I think we can do it after the post test. So Marissa can post the correct answers for those. Okay. From gender stated, we see that males seem to have higher activities of 3A4, 2D6, 1A2, and 2E1. Does that necessarily mean males are usually larger too? The liver may be a little larger, but we've measured that. Whether this really plays into whether males can metabolize quicker than females, I don't know. There's not been a real push that we're going to be dosing differently in males versus females for most drugs. We also see that this glucuronidation, which is part of that metabolism, that phase 2 portion, we do know the fetus is limited to how to be able to detoxify different things. One of the things that you see, for example, jaundice occurs in a lot of young infants when they're first born because their liver just can't detoxify the bilirubin. And so another thing is glutathione is an enzyme, is a compound that's used to inhibit free or to decrease free radical use or free radical production. And so the fetal liver is significantly lower. It's about 20-fold lower than adult livers in being able to do that. We see that there is some pathways like sulfation seems to be more important in kids, whereas glucuronidation is more in adults. That changes. But these are some things that may account for primarily the scenario of differences between adults and younger individuals. So what we find is, and this is pretty straightforward from a standpoint, is that, but we forget it. Okay, you guys are too young to probably have seen. As I was coming through, pharmacology and so forth, I remember that years ago when I first started, in this area, one of the things was you walked in and you go to a GP because you had this and everybody got the same thing, okay? Then we went to what is called sort of patient profile or patient profiling, I guess, which would be, for example, if you were a white male or if you were white, you came in, you got this type of drug. If you were black, you got this type of drug. Or if you were a kid, you got this type of drug. So it was more population in a sense based, but very loosely based. it was a little bit more specific, not really working. Because, I mean, for example, let's take blood pressure medication. So if you came in as you were hypertensive, basically, if you were a white male, you got ACE inhibitors. They were just coming out. People did not believe those worked well in black individuals, and older individuals. Black and older individuals tend to respond more to diuretics. So we had that sort of thing. And now we've moved to more what we call patient individualized medicine, which the idea is that, we are looking at you as an individual, your background, your specifics. We've known for years that there is that patients differ in how they respond to drugs. Some people responded, were very sensitive to the drug. Some patients were very resistant to the drug. And those were explained probably by pharmacokinetics, how the drug was being distributed. Now we know it's also pharmacodynamics. We know that there's inherited differences that can vary. We also know that as we go through our lifespan, our genetics doesn't change, but what does change is the development of, how our kidneys, how they develop, and how they hold out, how the liver holds out. So in the same individual, we will see that they will differ over their lifespan. We may use one drug when they were younger, and as they go on, we may try and go to another drug. And this is partly due to there are individual differences, and plus, we have to figure in that these emerging comorbidities that can occur. So a key point, which everybody, I think, agrees on, is it's important in individualized therapy and to monitor the patient closely, especially on chronic. Now, I think everybody agrees with that, but one of the things that you start seeing is sometimes in practices, you start seeing cookie cutter. So if you're seeing primarily depressed patients, you will see some docs that they have a go-to medicine and they're going to try that every time because they're comfortable with it. And that, in one sense, you might say that works pretty well or can work. But on the other hand is that some of those individuals, they may see that there may be reasons why you might want to try a different medication. A lot of times what we saw is that the docs always like to try what the new drugs were because basically they got samples and the drug reps came in and the drug reps briefed them. We'll talk a little bit about some changes in that lately. You guys don't get detailed when you start prescribing. I bet you will be detailed. Although I have seen one place where that the person told me because the MDs didn't think psychologists should be prescribing, those individuals, the drug reps wouldn't come see them because they were afraid that MDs would not prescribe. So what we need to do is that we do recognize that we want to pick the drug for that particular patient. But the other thing is the monitoring. We need to monitor the patients. And sometimes, if you're dealing with a drug like clozapine, then everybody's going to monitor pretty closely. If you're dealing with a drug like, let's just take Effexor or something else, people may not monitor as readily. So one of the things that we see is that it's important for us to choose the medicine best for that particular patient. And secondly, we need to review what that patient is doing, because one of the things we do in this society, in our world today, is we tend to add drugs, and sometimes if it's working, we don't take it off. Or we tend to start doing what is known as polypharmacy, where that when side effects emerge, we just simply give you another drug for the side effect. Psychologists in general, since they've been prescribing, it's been my experience that although they were promoted or the MDs, a lot of the MDs said, you guys are going to get a prescription pad and start just burning up the prescription pads. I've seen more of the prescribing psychologists pulling medicines than anything else. They tend to be reducing medicines, which is good. Now, let's go ahead and take our first morning break, and then we're going to come back and talk about some age-related changes. So let's see. Let me answer this question first. Janelle, you're asking a very good question, and this is one of the issues that a lot of people are coming into, because people that are in practice, let's take general practitioners, that's one of their concerns. It's hard for them to stay in practice because literally they have to see X number of patients in order to stay solvent. And so a lot of times you're seeing team approaches, you're seeing more use of PAs, but one of the things that will happen is you will find in each class of drugs specific drugs that you feel comfortable with that will be what you will start off on in. But this is going to be a different issue. A 30-minute appointment is going to sometimes to be difficult. So you're going to have to, some of this may be reviewing charts after the patient is getting the lab test back, requesting certain lab tests, and then it's going to be a difficult thing to do. Is a lot of I get tickled at psychiatrists because they have a med check, which is 20 minutes. Well, they're just checking on meds. How are you doing on your meds? Any side effects? Those are about it. They don't go into really any of the psychotherapy. They leave that for you guys. So that is, that is going to be something that is going to be difficult to do. Is as we use these drugs. I mean, again, if you're good about getting the patient on the right medicine and the patient is being compliant, you're good. And then that gives you time. But that is going to be a challenge. It is definitely going to be a challenge. Okay. All right. So let's take our first break and let's come back after. Let's come back at 1/4 after the hour. Marissa, I sent you an article to post for the students for them to look at when they break for lunch. So let me know if you didn't get it. Thank you very much. You're too efficient. Okay, guys, let's go ahead and get picked back on where we were talking about. So a lot of the, one of the things that we're dealing with too, as I mentioned a few minutes ago, that as an individual's life changes over life, their response to drugs are going to potentially change. And so that's something we need to be aware of. So let's look at some of the things that we do see and maybe some of the consequences that can occur. So let's start with the GI system, okay? So one of the things as you age, what we start seeing is that the pH of the stomach starts changing. And basically, this can have a couple of important things. One of the issues is going to be with gastric pH changing is that the older individuals may be more susceptible to development of ulcers, okay? Both in the stomach as well as in the small intestine. So both you may have an increase in gastric as well as an increase in duodenal ulcers. So that's an issue that can arise there. The other thing is that sometimes the change in the pH of the gastric pH can also alter how drugs may be absorbed, because as drugs are broken down, they're going to be, the pH may affect how they're ionized, and that may affect how that they're absorbed. So that may be one thing. Another thing we see is that the GI system is sort of slowing down. A lot of older people start, one of the things that's sort of indicative of this is that some of the older people will start expressing, for example, they may be more constipated. But big thing is gastric emptying slows down, so it takes longer for the for stuff to move through the stomach. So when things stay in the stomach and you've got a change in pH, that can cause a deterioration of drugs that may go through there. They may be more susceptible to GERD, because as the food stays in the stomach a longer period of time, it has more chance to, reflux back up. The other thing is your time to onset of a drug may increase. So basically, it may take a little longer for the drug to get there, and the effect may not quite be as prominent as you had before. These are some things that come into play there. So the other thing we see is that, and I don't know if any of you have patients that may experience this, but there's a condition known as gastroparesis. Gastroparesis is sort of a slowing down, and so what these individuals have, I know my wife has it, and it's saying that a lot of times they have nausea. They have a lot of they don't feel like eating because they're nauseous all the time, and we can treat it with a number of drugs, but sometimes these drugs create side effects of their own. But this is particularly this can be a problem in diabetics specifically, but in older people it occurs too, where that there is this decreased or delayed gastric emptying, so it sets up for all of these problems I just talked about. The absorptive area of the GI tract actually decreases, and part of that is because over the years you may have some damage and so forth. You get scar tissue there, and so there's a chance that you're not going to absorb the drug as well. This can vary between individuals. And then we also have the blood flow that supplies the stomach and the GI tract, which is known as the splanchnic blood flow. We usually see decreased blood flow. So if we have decreased blood flow, how is that going to affect drug action? Right. So it's going to basically, part of this decrease in splanchnic blood flow may be due to atherosclerosis in that particular area. But one of the things is going to be is that where the GI tract is there, it's absorbed, it goes into the splenic blood flow and then circulates. So one of the things is it can delay entry into the body, and so that can slow things down. So we have to take that into account. And another thing that's important is when we are looking at these type of situations, you got to consider that, for example, the person, if you have a drug that needs to be taken with food, the person doesn't want to do that. Some of the drugs may increase the nausea. Some of the drugs may irritate the stomach more. So these are things that can occur. And when that occurs, then this can ultimately affect compliance. So these are things that you need to be aware of that could come into play with regard to this. We may also see, because of these things, patients may be taking a lot of over-the-counter remedies, things like antacids and other things that kick in that may tie up drugs. So there's a lot of different things that can play into this. Again, the pharmacokinetics may be slightly different in these particular patients, and that is may be due to these age-related changes. So we definitely have to be aware of that. Now, the other thing is that we do see changes in body composition as you age. We see that there is your lean body mass basically goes down. So we get increased adipose tissue. So basically, the change you get is you get more fat and less lean muscle. Typically, we'll see an overall decrease in total body mass. Now, typically, we're not going to dose drugs. We don't dose drugs by weight. But the fact is that theoretically, there could be some important things that come into play with regard to how the drug is distributed in the body, which could theoretically affect or may account for some changes that we see. Rebecca, you brought up a very good point, which I meant to mention in just a few minutes ago. We do have a lot of people that have undergone gastric bypass surgery, okay? So what gastric bypass surgery is, typically what they're going to do is, and we have a lot of younger people, more, than we used to have. Usually the gastric bypass surgery was used only in very obese people, but we have seen that there are physicians that are doing banding and so forth, even in people that are not, quote, obese. But that has created a new issue because, for example, what typically happens is you're banding the stomach and making the stomach smaller. And there's a couple of things that occur as a result of that. One is that the transit time going through a smaller stomach is going to be shorter. So what we may see, and there's a concern about, there's been a few studies that have been done on a few drugs. So one, there's been some reports about when people drink that have had bypass, is the alcohol gets to the small intestine quicker. So they may show a quicker absorption or quicker onset of the effects of alcohol. There's been a couple of papers, I think they've looked at benzodiazepines. So one of the things that happens with gastric bypass changes is that the drugs may actually get to the small intestine, where most drugs are absorbed, or the absorption occurs primarily in the small intestine. And so the drugs may get in quicker. What all other changes may occur. For example, there may be some changes in fat absorption and things like that, which could potentially affect lipophilic drugs. I don't know, but there are changes that are occurring, and it could affect that in general. Going back to the body composition, the thing about it is, what I always tell my students is, there's people that say, they're in their 60s or 70s and say, I'm the same weight as I was when I was in college. And so let's say if they weighed 185 in college and they weigh 185 now, if you were to look at their body mass composition, you would see that the college weight most likely had more lean body weight. Even though the weight is the same, you would still see typically the older person was going to have more lipid, more adipose tissue than they would if they were at 185 in college. Okay, now some other things that may change that could affect how a drug distributes throughout the body is typically the plasma albumin concentrations go down. Older people, as their liver function decreases, they're not going to be making as much albumin, so that could affect drug binding. Especially this would come into play primarily with highly protein-bound drugs. We've already talked about hepatic function decreases. Primarily the activity, again, that the metabolism decreases primarily not because the enzyme activity decreases, but because the liver size gets smaller and the hepatic blood flow goes down. But probably of all of these changes we're talking about, the one that comes to play that is probably the most important is this last one. This is the changes in renal function that occurs with age, where older people show a reduction in GFR. Basically, those changes are responsible for us when we dose. A lot of times the product literature will say something along the line of, if 62 or older, or it may say if the GFR is below this, then reduce the dose. And so when we are reducing the dose in older people, it's primarily because of the reduction in renal function, okay? It's not due to the change in body mass. It's not due to typically the liver, but it's basically the recognition that when you start hitting in your late 60s and 70s, you've probably seen 20 to 25% reduction in GFR, okay? People aren't going into renal failure. It's just that their kidneys have slowed down. So there is the potential for an accumulation of the drug. So that's when we do adjust drugs dose in elderly patients, it is primarily because of the reduction in GFR in renal function, which occurs as a result of age. Now, let's talk about a little bit more of pharmacokinetics. All right, so I have a paper I would hope that you guys will look at. It's about 5 pages long. It's a good reference for you. It's called Pharmacokinetics for Psychiatrists. And it breaks down pharmacokinetics and goes through it in a little bit more detail than what I'm going to go with. So if at all possible, when I let you go for lunch, what I would like for you to do is if you at least peruse over that during lunch, so we can maybe touch on some issues, or maybe if you have questions about it, that would be, we can talk about that paper when we get back. But as I said yesterday, pharmacokinetics is basically, it's how the drug is. We use a couple of terms. Pharmacodynamics refers to the interaction of the drug at the really at the receptor or the enzyme, okay? Pharmacokinetics is how the drug actually gets there and is removed from it. So we typically in medical journals, they will refer to this as ADME, which stands for absorption. I keep saying it's absorption, distribution, metabolism. How does the drug get to where it needs to go? So how is it absorbed, whether that's coming from the GI tract or coming from, if you've given a subcutaneous or an intramuscular, when you do an IV injection, you don't worry about absorption because it's going straight into the bloodstream. So absorption is really talking about how it gets to the bloodstream and then the distribution is what tissues does it go into. Metabolism is how it's broken down, and excretion is how it's gotten rid of. And all of these are sort of interactive there. Now, this, I'm not going to ask you about this formula, but it's one that you might find useful. This is a very simple formula that we use to estimate, for example, if I would like to find out if I give a certain dose of drug, how much is going to be in the blood, this can give me an estimate. So what you do is if you take the amount of drugs, so let's say I gave 10 milligrams and then I can look up the volume of distribution. And the volume of distribution, if you just put in whatever the drug is and put volume of distribution, you typically will get numbers. They'll give you, many times they'll give you a volume of distribution. It may give you a volume of distribution in children. It may give you a volume of distribution in males versus females, depending on the particular drug. The volume of distribution is usually in liters per kilogram. And I multiply the volume of distribution by the person's weight, and that will tell me the specific liters of volume of distribution in liters. So then that will, if I divide that, that gives me, by the dose, that gives me milligrams per liters, or milligrams per mil if I want to convert it. So I can use those to give an estimate. And so sometimes if you're trying to figure out, you can have the pharmacist do it in the place that you work. But for example, if I get I use this a lot of times with, if I get somebody's blood value, and then I'll find out, I can calculate and figure out roughly how much dose they're taking. But I can, so for example, I can take the concentration. If somebody says, you know, that I've got, we pulled the blood on them and they're showing 10 milligrams per milliliter, or 10 milligrams per liter, then I can rearrange this equation so I can actually calculate up the how much drug, roughly how much drug they took. Now this can be more complicated, because we can factor in bioavailability, and we can factor in half-life and so forth, and figure out some other things. But I use this as a quick one to sort of figure out, if somebody pulls a blood and they says the patient has this amount in it, and we're worried about the patient potentially taking, maybe not being compliant, taking too much, then I can sort of back calculate, and gives me an idea of what they, how much drug they potentially took. So I just put this there. I'm not going to ask you any questions on it, but you do find it's useful. All right. Now, these terms and everything that I'm using now will be reinforced when you basically read this paper at lunchtime. And again, this paper will be is a very good reference for you guys to have and refer back to. So, and your pharmacist gets a lot of this. We teach them. This is one of the most dreaded courses our pharmacy students have. They end up having one full course, one full semester just on pharmacokinetics, and they have to do all these different calculations. But the pharmacist should be well versed in that. Okay. So, and a lot of these calculations that come into choosing the dose and how much you give has been done as a result of the manufacturer coming out with recommended doses. Okay. So the volume of distribution, like I said, it doesn't have really an exact physiological significance. It's basically a calculated number. Okay. And again, as I said earlier this morning, the volume of distribution is really talking about how much volume does the drug distribute in the body. Okay. Lipophilic drugs will always have a higher volume of distribution than hydrophilic drugs. Okay. Because there's more fat and lipid than there is water in the body. Typically, most of we're talking about the hydrophilic drugs, a lot of it will be contained within the plasma or within the blood volume. But sometimes, so usually lipophilic drugs will exceed, their volume of distribution will exceed the volume of plasma or volume of blood. Okay. So what we find is that dosing is usually proportional to the volume of distribution. So the larger the volume of distribution, the larger the dose. Pretty straightforward. Okay. So we use this to sort of determine how much drug the manufacturer has done this when they give the dosing. So what it's really done is, I'm saying, it refers to the space or compartment in which the drug basically distributes. So the higher the volume of distribution means there's a larger volume, which means that it's distributing into the tissues. Okay. And what volume of distribution is dependent on is drug penetration into tissues, so how lipophilic it is. And it also will account for protein binding. So a drug that is highly protein bound will have usually a higher volume of distribution than a drug that's not protein bound. So what I'm trying to do in this next, time frame that we're looking at is just really give you a definition of some of these terms that may come in. And again, the article is going to be very good. Even though the article is a little old, it's still a very good sort of summary of pharmacokinetics, okay? Now, another term that's used is clearance. And when we talk about clearance, we usually think about the drug being cleared from the body. It's actually measuring the removal of the drug from a certain volume of plasma during a given amount of time. So it's really, we use the term clearance because we're talking about it's being removed from the body and being removed, but it doesn't really clearly and exactly indicate how much drug is being removed. It's really representing the volume of blood that basically is being cleansed of the drug in a given time. But the reason they use clearance a lot of times, the idea, if the drug is being cleared, it's being removed from the blood, and supposedly if it's removed from the blood, then it's basically going to ultimately be removed. Now, sometimes we'll talk about total body clearance, so that's being removed from the body as a whole. Sometimes we may talk about renal clearance. It's what's being removed by the kidneys. Sometimes we may talk about liver clearance, which is what's being filtered through the liver and being removed. And so those are the terms that we're sort of using. So when we're using CLT, that's the total body clearance, renal clearance, and then sometimes the liver, they'll refer to it as metabolism. So how much of the blood is being filtered and cleared of the drug that's going through the liver. What determines clearance is pretty straightforward. Think of it like this, is if you're running something, if you're going to try to clear it out of a system, regardless of what it is, one thing is going to be the blood flow or the flow through the whatever you're clearing, okay? So drug clearance by the kidneys, by the liver, whatever, is going to be determined by the blood flow through that particular organ. And it's also going to be determined by how effective that organ is in removing that or extracting the drug, okay? So one of the things is that if we have renal failure or cardiovascular disease, things that drop our renal blood flow is going to reduce the ability of our kidneys to clear stuff out, simply because that the blood flow is not, we're not bringing enough of the drug in for it to be cleared rapidly. Or if our kidneys fail, then what's happening is the extraction mechanism is not going to work. So typically when we have conditions where blood flow is reduced to the kidneys or to the liver, which can occur with cardiovascular disease, then what happens is it reduces our body's ability to sort of clear the drug out of the plasma. And when it's in the plasma, if it's active drug, it still has access to the tissues. All right. That scared me when I saw a blank slide there. So when we look at metabolism and elimination, that's going to be an important thing for us, because when we give a drug, we want the effect to occur. We don't want the drug to accumulate. We want the effect to occur, and we want the effect to diminish. And then the next time we give a drug, next time we give another dose, then we're going to go. So one of the things that we look at with these drugs are half-lives. And you guys basically know what a half-life is, which is a simple definition of that. A half-life is the time it takes for the body or the blood, whatever situation you're talking about, is when usually we're talking about half-life, we're talking about the body. So how long it takes for the body to basically reduce the amount of drug in half. So if I give 10 milligrams and I want to know what the half-life is, I need to know how long it takes for the body to drop the 10 milligrams down to 5 milligrams, okay? So if that occurs in 5 hours, then that's going to be my half-life of 5 hours, okay? And so when we're looking at this, basically, this is going to give us an idea of how long we anticipate the drug to be around, okay? So the plasma half-life, now this is an important thing for you to be aware of. So plasma half-life is how long it takes for the plasma concentration of a drug to drop to 50%, okay? That's what is in the blood. Whole body half-life is how long it takes to eliminate half of the body. It should be half of the, that's correct. How long it takes to eliminate half of the body content of a drug, okay? So a lot of times we're talking about half-life, typically we're talking about the blood, okay? So plasma half-life is typically 50%, and both half-life is going to be 50%, but plasma means reducing it from the plasma, and whole body means removing it from the body. Sometimes they'll say tissue half-life, which in some experiments they may be looking at, for example, they may be looking at, how fast does it get out of the brain? What's the brain half-life? But when we're talking about whole body half-life or body half-life, we're talking about how much is to remove it from the body. Now, what can affect half-life? Your age. Because think about it, how are we moving it? We're using it, many times we're moving it by a lot of mechanisms that may decrease as we age, okay? Kidneys, very important. A lot of times if we have people that have kidney failure or kidney dysfunction, we're going to see that the half-life is increased. And sometimes the half-life can be increased huge, okay? And that we have to be very, very careful with. Liver metabolism, same thing, is that with liver problems, that can affect half-life. The drug can stay around quite a bit. And then protein binding, why would protein binding affect half-life? Does anybody have an idea? So Arnold, what you would do with whole body half-life is basically what you're going to do is that you're going to, you can measure blood and urine and see to when it goes through. Because I mean, after something leaves the blood, it goes to the urine. So you could measure blood and urine and you see the blood half-life and then the urine half-life. So when we do a pharmacokinetic study, this is a good question. So when we do a pharmacokinetic study, literally what I'm going to do is I'm going to give a patient the drug, all right? What I like to do is I like to give the patient the drug IV if possible. So the IV, and I then also like to give the patient after a washout orally, let's say for a typical drug. So the oral versus the IV can give me an idea about bioavailability so I can tell how fast it's absorbed. But typically, let's see if I can draw this here. Try yellow pen color and see if, okay. So what we'll do, that's a horrible color. There we go. All right, so we give the drug and then we'll monitor it. So what I'm going to do is I'm going to monitor when it comes up until it's completely out of the system. So this will be 0 time. And then for a typical study, if I know how to do that, and Jason, I think you're correct on that. I'll come back to that in a minute. So typically what I'm going to do is I'm going to give the drug and then I'm going to take blood samples and urine samples for the next, let's say if I think the drug has a half-life of 6 hours. Okay. So what I'm going to do is I'm going to take, for a typical oral drug, I'm going to take from you, if you're having you in a pharmacokinetic study. So I'm going to take a sample at 0, which should show 0 drug. I'm going to take one at possibly 5, 10, 15, 30, 45, 60, 90, 120, then usually 180 minutes. So that's 3 hours, then 4 hours, 6 hours, 8 hours, 12 hours, usually 10 hours, 12 hours, and then maybe at 14 hours, 16 hours, 18 hours, and 24 hours. So I'm going to take a blood sample and I'm going to measure that and I will get a graph sort of like this. So this will plot out what it is, and then I can tell when the drug is completely. And basically what would happen is that by measuring the urine, I could be assured that it was completely out of your system, okay? So that's how I would determine that. So, and that's done in the clinical studies. It's done in the preclinical studies and the clinical studies of every drug that's approved. Okay. And Jason, you are correct. So what happens is, in a sense, well, you're partially correct there. I think you got the main thing is basically what happens is when it's stuck to only the drug that's free can leave. So if it's protein bound, it's going to stay there until the free drug leaves. Then it releases from the protein. So it's your big part of your answer is correct. So the protein binding basically keeps it in the plasma tissue, and so drugs with protein binding, high protein binding, usually have longer half-lives than a drug that doesn't. Okay, and so these are the things that affect half-life. And so one of the concerns we have is, like, for example, older people, the half-life may be changed primarily because of their kidney changes. But our concern is this: if they tell me that a young person, let's say, middle-aged adult, someone in their 30s, 40s, 50s, basically, if their half-life is 6 hours, and I'm given if it's a half-life of 6 hours, typically we're going to dose the patient every 4 hours. Okay, so if I'm dosing them every 4 hours, that usually keeps my blood levels pretty even. We get them at steady state, which we'll talk about in just a minute. So what happens is, if let's say I'm dosing a 70-year-old person who's got some, maybe their kidney function's decreased, and if I'm dosing them every 4 hours, every 6 hours, like 4 times a day, well, if their half-life is now been pushed out to 10 or 12 hours, then they're going to get toxic. We're going to have side effects. If I'm giving them a drug that's sort of one of the side effects can be sleepy, cause sleepiness, then they're going to be zonked. Probably after about 2 days, they're going to be zonked. A day and a half, they're going to be taking so much in that's not going to be eliminated. So the drug starts to accumulate. So, and on the other hand, if something happens where we do have somebody has a polymorphism where the drug metabolism is very, very rapid, then it's chewing through it. So they're going to be subtherapeutic. So what we see is that there's two things, and I don't want you to get caught up in this, but most drugs are eliminated through what we call first order kinetics, okay? Which means that a constant portion or fraction of the drug is eliminated per unit of time. So when the drug concentration, so for example, first order kinetics, if I give 100 milligrams, then what's going to happen here is going to be the first half-life. What am I going to go to? I'm going to go to 50. So the next half-life, I'm going to 25. The next half-life, I'm going to 12 and a half. So what we see is when the drug concentration is high, the rate of disappearance is high. Okay, so I went from 100 to 50. Okay, which was a change of 50. The next half-life, I'm going from 50 to 25, which is a change of 25. And then the next half-life, I'm going 25 to 12 and a half, which is a change of 12 and a half. So when the drug concentration is high, the rate of disappearance is high. Most drugs are eliminated this way. Okay, what you have down here is how we sort of calculate what the half-life is if we look at the disappearance of the drug over time, this is in the left-hand graph, and we plot it out on a semi-log scale, then by calculating the slope, we can calculate the half-life. And that's how they actually calculate it. I just want you to know most drugs are eliminated by first-order kinetics, which means that when the drug level is high, we're going to eliminate the rate of disappearance is high. Okay. Now, there is a slight different type of kinetics, and that's called zero-order kinetics. Phenytoin, which is an anticonvulsant. I think alcohol is also eliminated by zero-order kinetics. Okay, yeah, alcohol is. So in this case, the rate of elimination is constant. Okay, so it doesn't matter what the drug concentration is. The rate of elimination is constant. So there's a constant amount eliminated per unit of time. Okay, let's see if this next slide shows you. Let's see. So I'm going to jump ahead 2 slides. So first order, which is how most drugs are eliminated, would be you start from 100%, and basically what you're going to see is that it's going to be eliminated. So we're eliminating, let's say we're eliminating 10% each half-life. So with first order, if we do 10% of 100, that'll drop us down to 90. Then we do 10% of 90, which is going to drop us down to 81. So that's 9. Then we drop down 10% of 81, which is 8, 72. Okay. Whereas with zero order, we're eliminating the same amount. So we're eliminating 20% each time. Okay. So we're going to see we go from 100 to 80, then another 20% is down to 60, to another 20% is down to 40, to another 20% is down to 20. So we're eliminating that. So the problem with this is, if you compare the two, is the first order elimination, which most drugs are eliminated, you're going to get the drug decreases exponentially with time. Okay. The rate of elimination is proportional to the drug concentration. And if we plot the log versus, it's linear. So in this case, key point here, the half-life is constant regardless of the drug concentration. Okay. So it doesn't matter if I give you 100 milligrams or 10 milligrams, the half-life is going to be the same. Okay. In zero order elimination is we're going to see a linear decrease with time. The rate of elimination is kind, and it's independent of the drug concentration. The zero order drugs we have more problems with regard to predictability and toxicity. But most drugs are going to be first order elimination. When we talk about some specific drugs that are zero order elimination, I'll show you how that comes into play. And again, with first order, we're eliminating 10% of what's there. If the half-life is each period, we would be reducing the percentage of what there. So if it went, first half-life would be 100 milligrams down to 25. So I'm cutting it in half. The next one is I'm cutting in half how much I have left. Whereas in zero order, I'm taking the same amount each time, regardless of what the concentration is. All right, let's see. Yep. So let's talk about steady state, and let me introduce this to talk to you these next 2 slides. We'll take our last break in the morning, and then we'll come back and sort of finish up with some of these things. We're going to take a shorter break. So steady state this is the amount of drug. What you've got, as the name implies, we're at a steady state, which means the amount of drug coming into the system is equal to the amount of drug leaving the system. So we get this plateau or dynamic equilibrium. Okay. So what we look at is that once they get to steady state, the Cmax, which stands for concentration max, so the concentration, the maximal concentration is going to be about the same with each subsequent dose, and the Cmin, which is the concentration minimum, which is the trough, is going to be the same. Okay, that's assuming the patient is taking the drug as prescribed. Okay, now how long does it take to reach steady state? Really depends on it's drug dependent. Okay, and that depends on the elimination and the rate constant. Okay. So drugs, and what we use to sort of assess this is half-lives. So we use the half-life to give us an idea about the elimination rate. Okay, so basically what we find is drugs with short half-lives reach steady state quicker than drugs with long half-lives. And the rule of thumb is that it takes 4 to 5 half-lives to reach steady state. So let's take a drug with a 2-hour half-life. Then it takes us 8 to 10 hours to get to steady state. Whereas a drug with a 24-hour half-life, we're looking at a 4 to 5 day. Okay, so we're going to reach steady state, and determine when you reach steady state, you use the half-life. Okay, now once you get at steady state, and you need to raise it. Let's say we need the person's at steady state and we need to increase, we need to get them up to another, to a new higher steady state or change the steady state. So we can increase the drug dose, but keep the dosing interval the same. Okay. Or we can do is keep the dose the same and give the drug more frequently. So either way, what we're doing is adjusting when it comes to that. Okay. So what steady state looks like, let's see if I have a slide so I won't have to draw it. All right, so this would be if you're taking multiple doses. So we give our first dose here, and this is our Cmax, which is this CP max stands for concentration in the plasma. So this is our first Cmax, and we come down, and this is the C minimum. We give another dose here. All right, so we haven't gotten rid of all that dose, so we build on it. This is with the after the second dose. This is our Cmax, and it comes down. We give a third dose, and we get another Cmax here. And then we give, this is coming down, this is the C minimum, and then we get the C max. Now we're at this, in this slide, we're going to call this a steady state, which means that with every subsequent dose, assuming we're giving on the same dosing interval and the same dose, that the C max will be right about here and the C minimum. So when we're looking at it, we're just going to be going between, we're going to go between this C max and C min. These are all building up to it. But once we get to between 4 and 5 half-lives, we're going to be where the C-min and the C-max are the same. So it stays at steady state over a period of time. And again, we're looking at 4 to 5 half-lives to get to steady state. Okay. All right. So let's take about let's come back at 5 after the hour, and let me answer this question here. That's why you sometimes do a loading dose, but what you have to be careful about when you do a loading dose, let's go back to this diagram, is when you do a loading dose, what you have to really be careful about is that loading dose, you're going to give a big dose up here, and then it's going to come down. So this loading dose, your biggest concern is you stand a chance for getting toxicity with that loading dose. So you got to be careful with that loading dose because you could get some severe toxicity. But you give a large dose to try to get them to steady state quicker. Right. Okay. All right. Let's come back at 5 after the hour so you guys get about 8-minute break. And then I'm going to flip through a couple of slides, so don't worry if you're there. If you look at the slides and they're chicken. And so 5 after the hour, I'm going to finish up this thing about steady state, and then basically we should break for around 2:25 or so. Y'all can take your 4-minute quiz, and then you can have time to read the article, and then we'll pick back up after lunch. So I'll see you guys at 5 after the hour. Okay, guys. So let's look at some more things about this, some pharmacokinetics here. So anytime that we are looking at the drug, this is a single dose of a drug. So what we've got plotted here is plasma concentration over time. So when we give the drug, this would be, you see that the drug is going to be absorbed. And what we find is there's going to be typically what is called a threshold of when we're going to get the effects of the drug. In this case, the onset occurs when the drug gets at this particular level. Anytime we dose, we're going to have to overshoot that. And so this is where we have Cmax. That is the maximum concentration in the plasma. Okay, and then it starts declining down until we reach a point where that we're below the threshold, and therefore the drug continues to decline, but we're below having any effect. So the duration of the drug is basically when we hit the threshold and then when we leave the threshold. Okay, onset is going to occur here. The time to which we reach this plasma level here is going to be referred to as Tmax. Let me just put that up here. So Tmax is the time at which we reach maximal concentration. Okay. The magnitude of the effect is going to be between the highest level, which is the Cmax, and then when we reach down to the when we reach the threshold there. So we always have to overshoot the threshold, because if we went right up to the threshold, the effect would immediately dissipate. Now, we mentioned about loading doses, and our biggest problem here is what we're trying to do is we want to get where this Cmax area, so the highest concentration here, we want to make sure that we prefer that Cmax is below when we get a toxic level. So when we do a loading dose, what we're actually doing is we're overshooting this, so that when we start giving the next dose, we're starting way up here, and we get to steady state quicker. But the biggest problem is this Cmax, because most drug effects, side effects, are dose dependent, that if we give too much, then we're going to get toxicity. And sometimes that toxicity may be severe. Okay, so that's a single dose that we see. And this sort of is just following it there. So looking at the same thing. So the peak concentration, which is what I call Tmax, would be right here. And well, here it is, time of peak, that is referred to as Tmax. And then when we're doing pharmacokinetics, we get an idea of the duration of the effect by actually plotting the area under the curve. And so that gives us an idea of how long the drug is present there. And you may see what is referred to as AUC when they're doing pharmacokinetic studies. We use that to calculate duration. We actually used to do this sort of the old way of finding the area under that curve, is by tracing it out and actually cutting it and weighing how much it is. Or we do it algebraically by forming these rectangles, and basically getting the area of each of these rectangles as we move, further on down. So there's some, we have a lot of programs that do that now. Whereas when I first started, I remember we were happy to get the first Apple computer, because what used to take us 3 to 4 hours to calculate, that computer actually calculated the pharmacokinetics in 45 minutes. We were so thrilled. Now, if I had to wait 45 minutes for that calculation, I mean, when the little red bouncing ball comes on my Apple and it's taken, I'm very impatient. But I used to remember that when we got the first Apple computers and put the program to do these calculations, we were so happy that they would do these calculations in 45 minutes. This is the multiple doses we looked at just a moment ago. So, again, when we're looking at getting to steady state, which is here, this would be 4 to 5 half-lives. And what we see is that we're dosing on an interval. So we do get to a point where that initially we get drug accumulation, and then we peak where that we are. The Cmax is the highest concentration, and the C minimum is the lowest concentration. And again, this is making the assumption that the patient is taking the drug as prescribed. Now, if they're taking it every 6 hours, and let's say they take it 5 hours and 45 minutes, it's not going to necessarily make a big deal. Where we get concerned is, like with pain medications, is that the pain starts coming back. So what they start doing is, instead of taking every 6 hours, they start taking it every 5 hours, then every 4 hours. The next thing you know, they're taking it every 2 to 3 hours. Now, you've seen this slide earlier, and I want you to keep in mind, so drug interactions are going to be important. And as we said yesterday, that drug interactions can occur due to altered absorption from the site. They can occur due to altered protein binding. We went through that yesterday. We talked about alteration in metabolism and alteration in renal excretion. Now, one of the things, we're going to talk some more about this, that when we're dealing with drugs, is there's a concern about adverse drug reactions. Okay, these are referred to as side effects. Sometimes it's referred to as an ADE. ADE basically stands for adverse drug event. And what is defined by the World Health Organization, an adverse drug reaction is considered an effect which is noxious and unintended and occurs at doses used in man for either prophylaxis, diagnosis, or therapy. Okay, that's ruling out that, for example, suicide is not looked at as an adverse reaction if someone intentionally tried to, kill themselves. Now, there are multiple types of these. I'm only focusing on two, type A and type B. There is a type C and type D. We're not going to worry about this. The most common adverse reaction is a type A reaction. Okay, what that is, it's an exaggerated extension of the primary or secondary effect of the drug. So it's dose dependent. So, for example, with blood pressure medications, a type A adverse event is that you get a hypotensive, or they develop syncope, they faint. Well, what's happened is the drug has lowered blood pressure too much, so it's an extension of its pharmacological activity. With an antidepressant medication, hypomania or mania would be an example where they got too much of the drug, and basically instead of going to the elevated move to the hypomania, they go to mania. Okay, dose dependent. Less likely at lower doses, more likely at higher doses. The intensity of it increases with higher doses. That probably accounts for 60% or so of most adverse drug events. Type B is what we refer to, there's a term which is not, you don't see it used a whole lot anymore. It's called idiosyncratic reactions. Typically, this is an immunological or allergic reaction. And I want to emphasize, and the definition they typically give are that it is independent. They typically say it's independent of dose or route of administration. Okay. The reason they say this is basically that the lowest dose that you have available, it can occur at. We actually know this is adverse, that this can be dose dependent, because we know that if someone has an allergic response and you give them a larger dose of medicine, they are going to probably have a worse allergic response. But generally, the main thing is it's generally immunologic or allergic. And the thing you're talking about is that the ADRs can be greater is when you give them in IV meds, because basically you're getting them straight into that. You're going to get a higher concentration to the site. Whereas if you take orally, if you give 10 milligrams, depending on what the bioavailability is, you're not going to get as high a concentration. So majority of drugs, these idiosyncratic reactions are basically considered the rare reactions, whereas the majority of ADRs are going to be just simply due to an extension of the pharmacological action. The ADRs are important. We find that we know that adverse drug events can increase morbidity and mortality. There's a lot of statistics on that. As I said yesterday, some people put that at the 4th or 5th leading cause of death in the United States. That is not including the ones that were with all the heroin and so forth. This is prescription drugs, okay? Estimated in some studies that roughly 5% of hospitalizations are due to an adverse drug reaction. And what's a little bit scary is it's estimated that up to about 11% of hospital patients, while they're in the hospital under care, may actually experience an adverse drug reaction. So this is an important component. One of the reasons why we have to be very careful when we're using drugs and try to minimize those. They are more common in age extremes a lot because it's what we talked about this morning about that when you're real young, your ability to handle those drugs basically is not developed. When you're real old, a lot of those drugs, a lot of those systems that handle it are basically starting to wear out. Now, this next statement is sort of an interesting. Women are reported to have 50% higher rate than in men. Part of that may be physiological, but it also may be due to that women are more likely to go to the doctor and more likely to take medications. So there's a little bit of skewing here that can occur from a standpoint that women are going to be exposed to prescription medications typically more than men. So, but we do still see that women tend to have a little bit higher rate than men. We also see, here's something for you to be aware of, is if a patient has a past history of a reaction to a medication, they're more likely to experience an adverse drug event, even if it's a different medication. So if a patient comes in and they've had some problems with medications, had adverse events, sort of let your little antenna perk up there, because it could mean that those individuals are at risk more so than other person that has not experienced an adverse drug reaction. Now, a couple more slides, and then we'll stop for this morning, and we'll let you guys test that. All right. So one of the things we used to have was what's called the FDA drug risk factors. These were actually developed in 1980 and were designed to determine or basically give guidance with regard to dosing women that may be pregnant or may be thinking about getting pregnant, or maybe just dosing women that have the potential of getting pregnant. The problem was that these were originally developed. They were very difficult to use in everyday practice. The categories were really never designed to be used in clinical practice. And a big thing was a lot of the pregnancy risk was basically due to lack of information rather than a specific known risk, okay? They didn't factor in trimester. So if you look at the pregnancy factors, and most of you have seen these, this was the risk factors that were put on labels. Drugs had to have an identification of the risk for that. So basically, a drug that was classified as an X means that there was fetal abnormalities or evidence of fetal risk that was documented in humans, okay? And in these that are rated X, pretty much the risk of use outweighed any possible benefit. These were drugs like, for example, some of the acne drugs we used to make individuals take pregnancy tests. You would not only have to take a pregnancy test, but they would have to stay on a form of birth control like pills. And so these were the worst. Most drugs, the best category you could get was A, which basically means there was no risk. Most drugs actually fell into C and D, which means that the animal studies, which were done in preclinical, we'll talk about some of those this afternoon, they showed risk, but we've never seen any risk in humans, or there was no studies that were available. And again, it was like, well, we're not sure, but you make the choice. And the D, which a lot of the drugs you would prescribe fall in that category, showed that there was positive evidence of human fetal risk, but you're able to use them. X, you don't use. So that was the problem, and I'll just move to the next slide. So the FDA changed the labeling just recently. And what the FDA now requires is, one, is that if there's a risk during pregnancy, basically they want a pregnancy exposure registry established. The company needs to do that. There has to be a summary of the risk of what is known and clinical considerations and provide the data. As far as lactation, which was not really addressed in the previous guidelines, is the companies have to provide a risk summary of what they see. And lipophilic drugs can get into breast milk. And again, clinical considerations that you need to factor in and data with what they have. And then also, if they were females and males of reproductive age, the issue of pregnancy testing, use of a contraceptive, and any effects that it may have on infertility. So the new guidelines are not as clear in one sense of being, or don't seem to be as quite as simplistic as ABCDX, but there's more data that's provided now, which is a big issue there that's there. Okay. Now, I think that is our last slide. It is. All right. So here's the thing. We're going to, Marissa will put the poll up for the 4 questions. If you will take this, she'll leave it up for 20 or so minutes. Marissa, you can decide what you need on that. Then you guys read that article, because there's a couple other things about pharmacokinetics that I want to cover that's in the article. So please read that article while you're at lunch. And then when we come back, we're going to look at the next slide set, which is really talking about drug approval and some issues about managing side effects and so forth. Okay. So we will return at lunch at 1 o'clock, but this will give you time for taking the test, and then you'll have time to read the article. So any questions? Okay. Well, I'm going to sign off here, and Marissa, if you will put the poll out for them, and then make sure when y'all finish that you do sign out and then re-sign back in this afternoon. And I hope y'all have a good lunch, and I will see you shortly. And again, please read that article so I can touch on a couple of points on that.